Good evening. Thank you for joining us here tonight. My name is Shireen, and I'm one of the founders of the Lyme Care Resource Center. Phil Kenny and I established the center for the purpose of helping people to heal and grow in mind, body, and spirit as we live with Lyme disease, either in ourselves or in someone we care about. Our community is also a place where the recognition of our shared experience serves to remind us that we are not alone. May is Lyme Disease Awareness Month. Like any awareness effort, the intent is to increase the attention to and appreciation for the subject. In the case of Lyme disease, there is a particularly powerful irony to the concept of awareness. Lyme disease is an illness that is often hidden and its symptoms unrecognized. Yet the patient can be so overwhelmed that there is little reprieve from the self-awareness that dominates each day. Those of us living with Lyme disease, as well as those living with many other long-term hidden health conditions, have experienced very similar scenarios. The body's natural inclination toward homeostasis is challenged. Balance becomes harder to achieve and maintain. Lyme has imbalanced us. COVID has imbalanced us. ME/CFS has imbalanced us. Dysautonomia and POTS have imbalanced us. So while our bodies, minds, and spirits are making constant efforts to balance and rebalance physically, mentally, and emotionally, what is the impact of stressors on a system that is already experiencing overload? Well, that's a whole thesis in and of itself, and we're not going to cover it tonight. But there is one stressor that we can increase awareness of this evening. For members of the Lyme community and those of other hidden illnesses, the challenges of dysfunctional homeostasis are compounded by the emotional strain of invalidation. When we then begin to doubt our own reality, we make efforts to normalize the abnormal state of our being, and that in turn leads to an even greater maladaptive response and further interferes with healing. In his book, Conquering Lyme Disease, Brian Fallon states, "The experience of being disbelieved and misrepresented over and over is inherently traumatizing. Some patients have identified this atmosphere of disbelief and the resulting social isolation and self-doubt as the single most stressful aspect of their illness experience." Some of you may have seen the movie Avatar. It is a futuristic story of human beings landing on another planet and attempting to conquer the native people of that land. When greeting each other, these natives to whom we are supposedly superior look each other in the eye and say, "I see you." This simple phrase encapsulates much of our ongoing struggle in the medical world. It speaks to a fundamentally necessary component of the practitioner-patient relationship that is at times absent in this journey with invisible illness. Many medical professionals may not know where to turn when blood work looks normal and verifiable analytical tools fail to provide objective evidence. The simple truth, however, is that an absence of evidence is not evidence of absence. That quote, often attributed to the astrophysicist Carl Sagan, can serve as an incredibly powerful guiding principle when it comes to illnesses like Lyme disease. Our lack of comprehensive and neatly packaged scientific proof need not preclude our awareness and acknowledgement of the situation. Rather, this is an opportunity for us to practice the art of inquiry as the necessary first step on the path of healing. And certainly, there is no one path of healing in illnesses as complex as Lyme disease. And that adds to the challenge for both the patient and the practitioner. The fractured Western paradigm of medicine, in its tendency to compartmentalize and classify health as black or white, present or absent, positive or negative, often fails to recognize the holistic nature of human suffering. But the path of healing is first paved with recognition of and respect for the imbalanced body, mind, and spirit. Our journey to regain and retain balance begins again each day. In paving this path, let us remember to turn toward the light, especially when it seems dark. And let us use the tools of compassion and understanding to help one another. Fostering awareness of this hidden yet ever-growing health pandemic will increase the opportunities for healing and will turn the tide against the history of glaring invisibility and deafening silence. We have as our guest speaker tonight someone who has made it his mission to foster the awareness of Lyme disease. He has paved the path of healing for countless Lyme warriors with sound practices and with stellar science. John Aucott and his amazing team at the Lyme Disease Research Center have partnered with many, first and foremost with the patients they serve, to produce the scientific evidence necessary to authenticate many of our struggles which we have experienced for months, years, or even decades, while seeking out the rare practitioner like him who looks at us and says, "I see you." For your endless support, for your validation of what we endure, and for your ongoing efforts to find the evidence that may have once seemed absent, we offer our endless gratitude. Our director, Gina Costa, will now join us with her introduction for the evening.
Hello, everyone. I'm Gina. I'm here to welcome you and thank you for making time to connect with us this evening. Happy 7-year anniversary to the Lyme Care Resource Center that was established by Phil and Shireen. It started with an amazing conversation 9 years ago that led to an amazing adventure in creating this nonprofit with the desire to provide compassion, education, and resources to help people in their healing journey. This May, for Lyme Disease Awareness Month, we created this opportunity to bring together patients, doctors, healthcare practitioners, nonprofit workers, family members, all of us that share a desire to connect, to help others. And the more that we gather and listen and learn, the more we can do. So thank you all for being here. There's a quote by Helen Keller that I love. It states, "Alone we can do so little, together we can do so much." And I believe in that. There's a lot of truth. When we gather together with the different hats that we wear and the gifts that we have, giving our time, our talents, our love, it's unbelievable what we can do together. So as we prepare for the night, I wanted to tell you a little bit about our focus. So we're all here to listen and learn from a world-renowned expert. We want to focus on compassion, understanding, resilience, and a chosen positive mindset. These are the core pillars of our nonprofit. Compassion for ourselves and others as we strive to be our best and give our best to others. Understanding to gain more knowledge to guide our decision-making and to make the best choices for us as we all strive towards optimal health. Resilience as we focus on the setbacks, but using them as an opportunity to regroup, to develop more strength. And this idea of the chosen positive mindset, it doesn't mean that we ignore our circumstances or our worries or disregard our sufferings, but yet we use the leverage to build strength in connecting with others, to educate ourselves, to empower us, each of us and our community, and to just make good decisions. I wanted to tell you a little bit about the format. Momentarily, Dr. Aucott is going to come on, and he's taken time to prepare a keynote talk for our audience. We're going to have a question, a discussion as time permits, and that will be facilitated by Ms. Nancy Doherty, and she's the communication consultant within the center. She's an amazing person that cares deeply about our entire community, and she's been an amazing asset to our nonprofit, just giving her time and talent because she believes in us and she believes in the mission and the need for compassion and more resources and education. The support of Dr. Aucott, Nancy, and the dedicated team at the center is so valuable to our mission in helping others. The deep commitment, the passion to help others through research, discovery, and innovation, it helps us to be successful. It gives us a comfort and a special hope. And we're so grateful for all of you. And I want to just say a couple words about Dr. Aucott, because I know that everyone is here because they know of his background and they know of the good work that he's been doing. But I'll tell you a little story about Dr. Aucott. He's the common denominator between Phil, Shireen, and myself. I was one of Dr. Aucott's patients. I experienced one of his SLICE studies about a decade ago. And it was a very difficult time in my life. And I had no previous relationship with him. He was my doctor when I was very sick and suffering, and I wasn't at my best. And I think that a lot of what Shireen spoke to is many people are trying to establish relationships with healthcare practitioners, with their doctors, when you're trying so hard to advocate for yourself, and it's difficult because it's a multitude of things that you're experiencing, whether it's an early diagnosis or whether it's long-term chronic challenges that many of us can relate to. The center was phenomenal to me. My relationship with Dr. Aucott and everyone at the center cared about me. It was a lot smaller at the time, but it was just the same feel as what they provide today, and a very similar passion, where I knew I had a team of people that cared about me and my progress. And I also knew that I was a part of something that could help the future of Lyme disease and tick-borne disease. So I'm going to tell you a quick story about Dr. Aucott, because as I went through a 2-year experience with him in the center, there was times I was doing really well and there was times I was faced with setbacks. And I remember I would talk to him as my doctor, and he would just say lots of encouraging things. And he would say to me, Gina, just envision the best you and keep striving towards it. You're doing all of the right things. He would give me so much support, but he never disregarded how I felt. And I knew I wasn't alone. I know that he did that for many other patients. And over the years, I have started working for this nonprofit more recently in the past couple of years. And I recently got an email from Dr. Aucott, and I'm just going to share it with you. But without reading the whole thing, it was around the new year. And he basically said, Gina, the work you are doing is meaningful and it's making a difference. He told me to keep striving to help one person at a time, because that's what really matters. And it's worth sharing this because I know that helping others is what fuels Dr. Aucott's passion to continue to build his team, to make positive differences in other people's lives, and to work relentlessly in this research, discovery, and innovation that the center has done and will continue to do. So at this point, I just want to share our extreme gratitude from the Lyme Care Resource Center to Dr. Aucott and Nancy Doherty and the whole team that is going to share with us some great information tonight. So I'm turning the presentation over to you, Dr. Aucott, and thank you for your time.
It's great to be here. Thanks for the introduction, and I really appreciate the chance to be here. Thanks, Gina, Shireen, Phil, and Nancy for making this all possible. So my goal tonight is kind of do a whirlwind tour of what's changed in the last year and how things have progressed. And so we're going to go through a lot of stuff. One disclosure, I'm consulting right now for Pfizer on using electronic healthcare records to estimate the true number of Lyme cases in the United States. I'm not working on their vaccine trial. So tick-borne diseases every year become more and more of a problem. And we all know this. And just to review for you, Ixodes scapularis, the deer tick, transmits Lyme disease, but that's not it. There's many other infections. Borrelia miyamotoi now, Powassan virus, anaplasma, and of course the malaria parasite like parasite Babesia, which is moving down the coast and into our region as well. And then the Lone Star ticks, which transmit Stari, which is a Lyme look-alike disease, southern tick-associated rash illness, and then the increasingly common and troublesome red meat allergy, alpha-gal meat allergy, transmitted an allergy by the bite of a Lone Star tick. So every year we get more problems associated with ticks, and there's more ticks in more places and more to come. So tick-borne diseases are primarily a Northern Hemisphere disease, but not exclusively. In temperate Northern Hemisphere from Japan, Eurasia, Europe, East, North Central, and Pacific West, and really everywhere across the Northern Hemisphere. And there's different species in Europe than there are in the United States. And then we're learning more about the Southern Hemisphere. And I think this is an evolving story, tick-borne diseases in Mexico and South America, Australia. So the story isn't over yet. We have lots of tick-borne diseases and there's more coming, and probably including areas in the Southern Hemisphere as well. Unfortunately, our ability to count cases of Lyme and tick-borne diseases is severely hampered. We started a Lyme tracker at Hopkins, the link here, to try to help with tracking Lyme disease cases, because here on this map, you'll see a snapshot of the CDC tracking, which is incredibly flawed now, underestimates the number of cases. And also you can see Massachusetts just stopped reporting their cases. So they're no longer capturing cases from certain states. And we all know that this number is an underestimate. And the true number of cases we think now is close to 500,000 new cases of Lyme disease a year. So this Lyme tracker is using novel ways to understand the number of cases. We're looking at laboratory test data. We're looking at Google search data and really trying to get a true estimate and a real-time estimate of where this epidemic is spreading as it spreads down the coast, spreads west, spreads up. It's a spreading insidious epidemic. So I estimate back of the envelope calculations, about half of the metropolitan areas in the United States are now Lyme endemic. This is my favorite slide because I'm from the Bay Area. You can see the deer invading from Marin County. San Francisco is in a Lyme endemic area. And so are all the major metropolitan areas on the East Coast. This is a map of Baltimore, and anywhere you see these green fingers of streams coming into the cities, whether it's Rock Creek in DC or Falls River in Baltimore, you have Lyme disease, not just in the suburbs and rural areas, but tracking down into the inner suburbs where these green belts support ticks, deer, infected rodents. So cases from Roland Park, Mount Washington are very common, and similar situations in all the urban areas in the East Coast. All right, move on. There you go. So climate change may also abet this spread. It's thought that climate change is allowing ticks to spread both to higher elevations and colder climates. And this is borne out by the researchers in Canada, which have shown the infected ticks now spreading up into Canada because of the warmer climate. Mice are proliferating, which are the reservoir hosts for Lyme disease. And so Canada is a good example of the impact of warming climate and the spread of infected ticks and hence Lyme disease. And so this is Lyme season. There's not a coincidence. May is the month we're doing this. Nymph stage ticks, which transmit a large percentage of Lyme disease, come out in May every year, just like clockwork. It's part of their life cycle. And these nymph stage ticks are hard to see. This is the infamous poppy seed ad from the CDC. Can you identify the nymphs from the poppy seeds, right? So nymph stage ticks are about the size of a poppy seed, except they have legs. And so if you look carefully, these poppy seeds have legs. Those are nymph stage ticks. And that's why it's so hard to see a tick bite, because these nymph stage ticks are small. When they feed, they numb up your skin. They establish this feeding cavity with numbness. They suppress the immune system. They anticoagulate your blood so that they can successfully feed for the 3 to 5 days that they'll feed. And so tick bites are a complex thing, but the bottom line is the faster you get off of a tick, the less likely you are to get a tick-borne disease. Unfortunately, different agents that are injected into the skin have different transmission times. So some are transmitted very quickly and others take a little longer, but the bottom line is the faster you get the tick off, the better. Tick bites are also cause these localized reaction. I like to show this to educate people the difference between a tick bite reaction. This is the local reaction to that tick bite feeding cavity. It's different than the rash of Lyme disease. This is small, the size of a fingertip. It doesn't expand and get big like a Lyme rash would over days and weeks. But this tick bite reaction can last weeks, actually, because it's an immune allergic reaction. I do want to mention also that the time you take a tick off, there are options for prophylaxis for tick bites. That only is appropriate in the first 72 hours after you remove a tick bite. It's different than the treatment used for established Lyme disease. It's prophylaxis that's done in the first 72 hours after removing a tick. And it's something that's an option that you can talk to your physician about if you remove a feeding deer tick this time of the year from your skin. So Lyme disease is a complicated illness. We're going to start to get clinical here now. It's a 3-stage illness like syphilis. It starts at the bite of an infected tick. The bacteria proliferate in the skin. And during that time, most but not all the people get a round red rash and a febrile illness. And this is without treatment. That rash eventually goes away as the immune system fights the bacteria. But unfortunately, the immune system isn't effective in eradicating all the bacteria that were injected into the system. And people relapse with neurologic disease or 2nd stage Lyme disease, usually around 4 to 8 weeks after the tick bite. That's also when you get carditis, infection of the heart. And then later on, and an average of 6 months later, is when people get late Lyme arthritis. So Lyme disease is like syphilis. If it's not treated, it's a persistent infection with 3 stages. All of these stages are due to persistent Borrelia burgdorferi in the human tissue because the immune system can't get rid of them. The bacteria evades the host immune response. So how do we prevent Lyme disease? So some updates from our clinical research. One of the things we're very impressed with is that we miss the diagnosis of early Lyme disease. It happens all the time. And one of the reasons we miss the diagnosis is, Allison Redmond did this research, is because people have the symptoms of Lyme disease often without the rash, or the symptoms come on before the rash. And so people have symptoms and see a doctor, and if they don't have the rash, people get misdiagnosed. And Allison looked at this very carefully and saw that if you had a rash, you had a 22% decrease in time to treatment, meaning if you didn't have a rash, it took 22% longer to get diagnosed and treated. And that's because these symptoms overlap with a lot of other illnesses. In fact, in the last 3 years, we saw people getting diagnosed with COVID because you get fatigue and headache and fever and chills and sweats with COVID too. And so if you only have symptoms and no rash, or the clinician doesn't recognize the rash, people get misdiagnosed in early Lyme disease. Now, even if you have the rash, unfortunately, people get misdiagnosed. And this is one of my crusades, is to teach people that the rash of Lyme disease isn't that easy to diagnose. It's not like finding the sign on the side of a Target department store. It doesn't look like this classic bullseye. Our group published this compendium of Lyme rashes from hundreds of people. And as you can see, only 20 to 30% of the patients had clearing of a bullseye. Some had central darkness. Mostly it was just uniform redness. Sometimes it even looked like a bruise. Occasionally 2% of people have blisters. And so all of these atypical manifestations, which make up 80% of the patients we found, are prime for early misdiagnosis. Patients and doctors still are looking for the classic bullseye and ignoring these other manifestations, calling them spider bites or other atypical non-Lyme lesions. This is even more of a problem in dark-skinned people, African Americans and others with dark skin, because as this patient shows you, it's hard to see the erythema migrans rash of Lyme disease in somebody with dark skin. And we published this case report calling attention to this difficult diagnosis in dark-skinned people. And part of the reason is there's very few images of EM rashes in dark-skinned people. I'm putting out a call right now to anyone on this call. If you have images of rashes in dark-skinned people, we desperately need them to teach people about the rash in African Americans and others. This has actually gotten prominence in the last year as different groups, including Lisa Negrovic's group, have published the lack of recognition of EM in dark-skinned people. In Lisa's study from pediatric emergency rooms, the Black children were much less likely to have the rash diagnosed and more likely to present at late-stage Lyme disease with swollen joints. So not only are the rashes not getting seen, but the children here, African-American children, weren't being diagnosed till late Lyme manifestations. So we're trying to improve the diagnosis of rashes through the use of cell phone images and using artificial intelligence to diagnose cell phone images of Lyme disease versus other conditions. And this is a project that is progressing nicely, and to teach machine learning AI to help us pre-screen lesion photos on our phones. And this is going well. The one holdup actually is we don't have images again of dark-skinned people. And so again, we're looking desperately for images to help train our AI applications on dark-skinned individuals. So I'm going to transition now to second stage Lyme disease, because half of the people or more with the rash have bacteria in their bloodstream. It spreads to other areas, including other areas of the skin, as you can see in this young man, and the nerve. Here's a seventh nerve palsy. So this is spread of the bacteria to the nerve and other areas of the skin from the primary lesion. And these other skin lesions actually often look very atypical. They can morph together. They're not classic circles sometimes. And so multiple EM lesions are very hard to diagnose. This third case was misdiagnosed and actually progressed to fatal carditis because of the lack of recognition of the disseminated multiple skin lesions. So carditis is one of the rare manifestations of Lyme disease, but very important because it's associated with sudden cardiac death because of involvement of the heart muscle. And we're taking a closer look at heart involvement in Lyme disease. My group, Allison Redmond, Cheryl Novak, and I have been working with Adrian Baranchuk, as you know, probably the world's authority on Lyme carditis. He's at Queen's University in Kingston, Canada. And Adrian, Dr. Baranchuk, is a world's authority on Lyme carditis. And we're working with him and published this review article to explore the phenomenon, not just of acute Lyme carditis, but potentially the involvement of Lyme disease with later stage dilated cardiomyopathy. In this review, explored this need for research into the later manifestations of Lyme disease and its impact on the heart muscle. So an evolving area really led by Dr. Baranchuk up in Canada. So now I'm going to transition a little bit to actually the specific diagnosis of tick-borne diseases. As I mentioned before, these symptoms of fever and headache and achiness are common to many infections. In fact, all tick-borne diseases look like this, fever, and not all of them have a rash. Even the Lyme patients don't always have rashes. And so we see a lot of misdiagnosis, and the reason why is because it's hard. So if you have a flu-like illness, it's May, it's Maryland, the chances of this being a tick-borne disease are significant. So how do you diagnose Lyme disease? Well, if you're lucky enough to have a rash, then I've just taught you all what the rash looks like, and you should be able, hopefully, to make the diagnosis. And you don't even order labs. If you have the rash and it's an endemic area, the right time of the year, you don't want to do a lab test, because I'm going to show you later the tests don't work in early Lyme disease. You diagnose based on the clinical scenario and the appearance of the rash. End of story, treat the patient and get the treatment early, and the patient will do well the majority of the time. Unfortunately, if you don't have the rash and you go down this arm of the tree, now you have to rely on blood tests. And this is where it gets difficult, because the blood tests for Lyme disease aren't like for COVID. We don't have a PCR test for Lyme disease. It's not like COVID where you can do a PCR and know you have the infection. We're still relying on serology, on both acute and convalescent serology, to make the diagnosis if we don't have a rash. The problem is we don't want to wait for a convalescent serology 4 weeks later. So the majority of people without a rash still are probably going to get treated empirically if they're ill, while we're waiting for the blood tests to come back, because we don't want to wait, especially if it's the possibility of Rocky Mountain spotted fever, where waiting can be a lethal decision. So lab tests are still used in early Lyme disease when we don't have the rash. And the problem is they don't work that well. Currently available lab tests for Lyme disease rely on antibody tests, ELISAs, and Western blots. We don't have what we have for other infections. We don't have culture that's available and reliable for Lyme disease. We don't have reliable sensitive PCR tests. We don't have pathology like we do in other infections. We're still in 1910 technology with antibodies alone. And that's what we're spending a lot of time in our research, is trying to find better blood tests for Lyme disease, because the false negative rate with these antibody tests is more than 50%. Only 40% are positive, because the immune system takes weeks to develop, and it's not going to be positive at the time of the initial presentation with a rash or fever. It takes weeks for these antibodies to turn positive, and they also don't act as a test of cure. You can't repeat a Lyme test and show that the person's better based on the Lyme test changing. They do not act as a test of cure, and they're unpredictable after treatment. They may become negative, they may stay positive. They don't tell you if the patient's getting better. That's still a clinical decision, believe it or not. And we're still stuck with this two-tier testing. The two-tier testing for Lyme disease is very complicated. It involves doing an ELISA first. If the ELISA is positive or equivocal, you do the second stage Western blot. If it's negative, then you have to wait 4 weeks and repeat it. It's a cumbersome and complicated paradigm, this two-tier testing. And it relies on these Western blots, and they're complicated. The IgM Western blot, which is used in the first 4 weeks of infection, looks at 3 bands. You need 2 to be positive. The IgG looks at 10 bands. You need 5 to be positive. It's very complicated, and it's honestly fraught with errors. So recently, the CDC has also offered a modified two-tier test. I mention this because you'll encounter this now. It's called a modified two-tier test. The first tier is still an ELISA, but now the second tier is a second ELISA. It's no longer a Western blot. It's a second different ELISA, but the 30-day cutoff for IgM and IgG still applies, so it's still very complicated. And to show you how it doesn't work well, this is a review article that looked at the two-tier testing positivity in early Lyme, 30 to 40%, i.e., you're better off flipping a coin than doing a two-tier test in the first few weeks. If you wait till you have neurologic disease, it's better, but the IgG two-tier test is still only 85 to 90% positive. It really only gets to be a really good test months later when you have arthritis. And unfortunately, the scenario we're usually in is doing an acute and convalescent. That's an acute test, and repeating it 4 weeks after therapy. And there you can see the two-tier testing. If it's a post-treatment convalescent test, again, falls down somewhere between 30 and 50% positivity. So convalescent antibody testing, if you've treated somebody at the acute phase, doesn't work either. Lots of problems with antibody testing. So because of this, we're working hard on getting better Lyme diagnostic tests. The LymeX Diagnostic Prize, which is a public-private partnership with Health and Human Services and the Stephen and Alexander Cohen Foundation, have sponsored a prize competition, actually, called LymeX, to look at better diagnostic ways to get more accurate early diagnostic tests for Lyme disease. They've announced 10 phase 1 winners that are advanced to the phase 2 of the competition. And these people are working hard. Actually, we're working with 2 of them. We started working with them before the competition, and we have a DoD grant with Tufts University and Lyndon Hugh to look at a new test for Lyme disease. And we're working with George Mason on their Lyme biomarker in urine. And we'll maybe working with the other competitors in this competition. So I just want you to know that there's a lot going on. This public-private partnership has been sponsored and is really sponsored by the Cohen Foundation and also Health and Human Services. And this, with any good fortune, will lead to direct diagnostic tests for Lyme disease, really in the next several years, that are a marked improvement over what we have now. So I'm going to transition now to treatment, antibiotic treatment for the first phase of diagnosis and treatment. We used to tell people that kids couldn't take doxycycline, but now that's been reevaluated. And so kids can be treated with amoxicillin if you know they have Lyme disease, but if there's any concern about Rocky Mountain spotted fever, they should get doxycycline. You don't have to worry about the tooth staining. In adults, we treat with doxycycline usually, and also occasionally with IV antibiotics if they have neurologic disease or difficult to treat arthritis. So, early diagnosis is the key so that we can get early effective therapy. And with early effective therapy, the prognosis is usually good. Treatment generally prevents later objective manifestations of late-stage untreated Lyme disease. But there's a big but, and I don't have to tell people on this call that there's a big but. it's not perfect. And so we've long known that 10% of people treated for late Lyme arthritis have persistent inflammatory arthritis. And I'm going to show you data that confirms what we've long suspected. And again, no surprise to this audience that 10 to 20% of people treated even for early stages of Lyme disease may develop Lyme disease associated persistent chronic symptoms. Sometimes I'll use the term post-treatment Lyme disease when I'm talking about research literature, but it's basically the same thing. It's persistent illness despite diagnosis and treatment with antibiotics. And that's what obviously is the huge area of concern that still is the area that, you know, keeps us up at night trying to understand how to understand the disease and how to help our patients. This actually isn't a new phenomenon. These infection-associated chronic illnesses have been around a long time. You know, there was a post-Russian influenza syndrome, post-Ebola, post-SARS-CoV-1. A lot of infections trigger chronic persistent illnesses. Epstein-Barr triggers chronic fatigue syndrome. Fibromyalgia may be triggered by viruses. I'll be talking about persistent Lyme and post-treatment Lyme. And now we all know long haul COVID, yet another infection that triggers persistent illness that is a huge problem and really is now, we in a way feel validated in the long Lyme field by the appearance of yet another, you know, epidemic of these post-infectious illnesses. There's been many names for this in the Lyme field. Sometimes in this talk, I may bounce back and forth between different names. If I'm talking about research, I'll use post-treatment Lyme disease. If I'm talking about clinical, I may use Lyme-associated persistent or chronic symptoms. Sometimes I'll use long haul Lyme. They're basically all the same thing. And they get called chronic Lyme too. It doesn't matter what you call it, it's real. The Infectious Disease Society published this case definition for research. And so when it's research, I'll use post-treatment Lyme. And it's basically this illness that follows Lyme disease. And the classic symptoms are fatigue, cognitive complaints or brain fog, and musculoskeletal pain. And it's serious. It causes functional decline. People are disabled. It's not a trivial disease. And you can't explain it by some other illness. In other words, this is a diagnosis of exclusion. The patients don't have something else. It's only can be tracked back to their Lyme disease despite antibiotic treatment of their Lyme disease. And it's a clinical diagnosis. Serology, the two-tier test I was telling you about, doesn't work for diagnosis because, as I told you, that's often negative in people that received early antibiotics. And there's really no objective biomarker yet. It's still a clinical diagnosis. And the symptoms and the symptom map, this butterfly map in post-treatment Lyme disease, it's the classic symptoms in our patients compared to controls without Lyme disease. You see fatigue. The dark bars are more serious fatigue that the Lyme patients have that the controls don't. The joint pain's more serious. The brain fog's more serious. The muscle pain, all the symptoms in the Lyme patients with post-treatment Lyme are more serious and more impactful than what you see in people that have never had Lyme disease. But the Lyme patients are very similar to long haul COVID patients. Again, fatigue, muscle body aches, difficulty concentrating, trouble sleeping. These long haul COVID symptoms look just like the long haul Lyme symptoms. So we knew when long haul COVID came out that we had yet another infection triggered chronic illness. So Shireen and Gina mentioned this issue of invalidation. This is what got me involved in this research. It's been now almost 15 or 20 years. It was when I started seeing people with chronic Lyme and I was told, oh, it's just psychosomatic. It's all in your patients' heads. They don't have a real disease. And that's what got us started 15 years ago with the SLICE study. This study was published last year since I spoke last year. And I just want to spend some time on it because I think it's an incredibly important study because I think it puts the end to this idea that long haul Lyme disease is just a psychosomatic, all in your head problem. This study was designed by Allison Redman. It's a beautiful study where everyone's enrolled at the time of their early infection with rash. They're all treated with standard of care doxycycline for 21 days. And they're followed for 6 months to the year with meticulous evaluations at each visit. And at the end of 6 months to a year, we characterize the patients as either having returned to health, 57%. So they had no persistent symptoms or illness. 30% had symptoms, but they weren't impacting their quality of life or health. So it wasn't clear if these symptoms were really due to the Lyme disease or more just what anyone would get. But the core group of post-treatment Lyme disease or persistent illness was 14%. These people had a new illness. It impacted their quality of life. It was impactful, and it could only be traced back to their Lyme disease, remember, despite early, not delayed early treatment. These people were diagnosed at the earliest possible stage and treated with standard of care therapy, and they still developed post-treatment Lyme disease illness. And it's way more than the controls had. So we had controls in this study to make sure that this 14% wasn't what you would just see in anybody. But anybody without Lyme disease, the controls only met this case definition in 4% of the cases. Obviously, they didn't have Lyme disease, but they met the other criteria. So the attributable risk was significant. And we think this study puts an end to the controversy about whether this is a psychosomatic disease. The relative risk of post-treatment Lyme disease in the cases versus controls was 5.2. So there's a 5-fold relative risk of developing post-treatment in the cases compared to the controls. And there was a 4-fold risk in female sex compared to male. So women at higher risk, and also 1.3 risk, relative risk in people that had traumatic life events. And these were all significant. In the group that had symptoms only, but no functional impact, I just want to point this out, that 30-some%, actually, the relative risk was much smaller, only 2-fold, and it wasn't statistically significant. So it's not clear in that third group that has symptoms without functional impact, whether that is attributable to Lyme disease. It may be partially, but it may also be what we call the hum of the population, what people without Lyme disease develop. And these days that could be people, with COVID. It wasn't in our study because the study was done before COVID, but now these could be people with COVID or some other illness that triggered it. But clearly in the people with impactful quality of life declines and severe symptoms, it was attributable to Lyme disease. And the symptoms we looked at, again, fatigue, muscle pain, joint pain, memory changes, depression, were all statistically significantly more common and severe in the Lyme patients than the control population. So I think that it's the end of the discussion that this is psychosomatic. There's been other studies that have come out at the same time that have confirmed this. And I think we need to move on to the real problem, which is figuring out the why question. Why do people get persistent illness related to Lyme disease? Why do these 14% are so severely impacted? And the way to find out the why is the second half of the slide study. It's all the blood samples that we collected at all those visits. So these blood samples are the biorepository that we established. It has over 70,000 sample aliquots now in the freezers at Bayview Medical Center. And this is the way we will understand the why of what is causing these people's illness. These blood samples allow us to collaborate with investigators all across the country. We've worked with over 30 different researchers at 20 different institutions to try to find out the why. What is going on that's causing you and our patients to remain ill? And so there's many theories, and I'll give you a quick overview of the theories that have been proposed to explain why persistent illness occurs in our patients. And one set of hypotheses evolves around microbial mechanisms, either persistence of B. burgdorferi remnants or bacteria or co-infections or changes in the microbiome that may drive ongoing inflammation and disease. So these are microbial mechanisms. There's also immune recognition mechanisms that our immune system may be altered by the infection, and then that altered immune system causes chronic inflammation or autoimmunity, changes in our metabolism, and that these take on a life of their own after the infection phase is over, and it's more immune dysregulation. And then third are altered neural networks, that this immune inflammation then alters our neurologic symptoms. That inflammation is not good for our nervous system. The cytokines aren't good for our brain and nerves, and that this may cause problems like dysautonomia or anxiety or depression, again, due to biologic mechanisms, central sensitization. And all these things, of course, that occur in the context of our host genetics. Not all people are the same, in the context of the patient's individual experience, and that some people have different illness experiences that have modified their illness trajectory, and that the different microbial strains may also impact the severity of the illness. So a complex mixture of mechanisms, and they may be different in different patients. There may be mixtures of mechanisms in each patient. This is the why that we're doing research on now. And we've published a lot. I won't review things I presented before with it, but we've discovered some biomarkers, CCL19, changes in transcriptome, changes in metabolism, changes in the microbiome that have been published that are clues to the mechanisms that I'll show you later are being translated into possible therapies. Since I spoke last year, we have, I think, a very impactful publication with Charles Chu at UCSF that looks at gene expression-based diagnostics. So the infection triggers changes in our genetic gene regulation and expression, and we're able to look at what genes are increased in expression and decreased. And these fingerprints of genetic expression are characteristic of Lyme disease, it turns out. And Charles Chu was able to put together a panel of different genes that can classify these 31 genes and classify Lyme patients differently than non-Lyme controls. So in essence, it acts as a blood test that identifies this fingerprint of gene regulation in the Lyme patients, which is different than the controls without Lyme disease. This has a huge advantage over antibody-based tests, because remember, antibody changes take weeks to occur, where gene regulation fingerprints change in days after infection, and allows you to diagnose seronegative Lyme patients from these gene expression patterns that occur almost immediately after infection. So this classifier is a possible new diagnostic test. Dr. Chu is working actively on this project to move this forward to a new diagnostic test. Another potential clue is coming out of our work with Erica Dara and Mark Solosky, is looking at an autoantibody called PAD2. This PAD2 antibody was used actually in an experiment by Dr. Dara to look at multiple sclerosis. And we're using the autoantibody PAD antibodies in the Lyme, post-treatment Lyme patients. Actually, she used them as a negative control, but they turned out not to be negative. The PAD levels were actually higher in the Lyme patients than the MS patients. So this was an example of serendipity. We actually discovered this autoantibody accidentally in this study that was really meant to look at multiple sclerosis, but pointed out that there's autoantibodies that probably are involved in neurologic disease that may be one of the causes of the persistent illness. These neurologic symptoms were things like focusing and concentrating, cognitive scores, memory changes, difficulty sleeping, and the autoantibody levels were actually inversely proportional to the scores on these neurologic symptoms. So again, a clue that inflammation may involve autoantibodies. These neurologic autoantibodies, like the PAD antibodies we discovered for Lyme disease, play into a long-standing theme in our research group that brain inflammation is a key part of the hypothesis about many of the symptoms, the cognitive symptoms, the brain fog, the fatigue, the sleep disruption, the anxiety. These are all neurocognitive symptoms, and we hypothesize they're from neuroinflammation. Our patients with these neurocognitive symptoms have lower scores on formal cognitive testing. And we showed several years ago that on PET imaging, TSPO PET imaging, that there's brain inflammation in our chronic Lyme patients compared to controls without chronic Lyme. So neuroinflammation caused PET imaging changes, and this inflammation on PET images is not good for the brain. So we reported this several years ago, but we've moved this research on to now looking at functional MRI in our patients with post-treatment Lyme disease. Again, looking for the impact of inflammation on brain, not now structure, but actual function. A fMRI is a functional MRI where we actually have the patients think while they're being scanned. And we hypothesized that the patients with Lyme disease, their gray matter, that they'd have to work harder during this cognitive stress test to get the answers right. And so we hypothesized that the blue activity in the frontal lobe, gray matter, would be increased in the Lyme patients because they'd have to work harder, but it was actually the opposite. It was decreased in the Lyme patients, and the controls actually had the typical frontal lobe activity in the fMRI. But paradoxically, the Lyme patients activated their white matter. So these red hotspots are down deeper in the brain in what's called white matter. This is like the wiring of the brain that connects the areas of gray matter on the surface. It's the wiring. And this wiring, the white matter, that's what got activated in the Lyme patients, not the gray matter. This was totally unexpected. No one's ever reported problems with white matter in Lyme disease. And we think again, serendipity led us to this discovery because these well-done studies happened to be done in a way that we found this white matter activations unexpectedly. And this may open up a whole new area, both diagnostics and treatment for the brain fog of Lyme disease, by understanding it may be a problem with the wiring, the white matter. These studies were supported by the DoD grant and are ongoing and are going to, I think, lead in the next few years to dramatic changes in the way we understand the brain fog of Lyme disease. This shows you that it's the white matter when they hone down in on the tracks, the actual white matter wiring tracks that were involved. So now I'm going to transition to the clinical approach to persistent symptoms, talk about diagnostics, testing, and treatment and prognosis. Again, the diagnosis of persistent Lyme is really a clinical diagnosis. It's finding the beginning of the story. I tell people I'm like Sherlock Holmes. They may come to me at chapter 13, but I'm going to dive back in and find chapter 1 when it all started. Every story is unique and it's a clinical diagnosis. Lab tests, again, aren't that helpful. Basically, they should be basically normal. If they're not, it may be a different disease. And the Lyme test isn't all that helpful, honestly. It may be negative or positive. The key is finding chapter 1 of the Lyme disease that started off the cycle of persistent symptoms. We do a lot of tests at the Lyme Disease Center that other people don't do that I think are important. We focus on a lot of areas that other people haven't focused on, including joint inflammation and doing joint ultrasounds to show inflammation, to obtaining joint fluid samples for diagnosis. We do a lot of central nervous system imaging, as I showed you, but also spinal fluid analysis and nerve tests. And then I'm going to be telling you more about autonomic dysfunction and using small fiber nerve biopsies and autonomic testing to try to create subgroups of different organ dysfunction that we can document and then focus our therapy on. New researchers in the Lyme Center in the last couple of years have dramatically changed our ability to diagnose persistent symptoms. John Miller, who's a card-carrying rheumatologist, is doing joint ultrasound and finding all sorts of evidence of joint and tendon and ligament inflammation on ultrasound. These are ultrasound signals of inflammation that allow him to obtain samples and diagnose inflammatory processes that can have specific treatments that are part of the persistent symptoms of Lyme disease. Britt Adler, who just joined us this year, who's going to be focusing on autonomic dysfunction in POTS. She'll be doing transcranial Doppler and tilt table testing and small fiber skin biopsy referrals, dorsal root ganglia imaging to document the impact of Lyme disease on the autonomic nervous system and how that may lead to POTS and the impact that has on fatigue and cognitive dysfunction. We've been looking at this COMPASS survey, which documents different aspects of autonomic dysfunction. This is a poster we just presented with our Lyme fellow, Britt and I, and showing that autonomic dysfunction can impact many areas of the autonomic nervous system, not just POTS, but vasomotor, dilatation of the vessels, GI, urinary symptoms, eye symptoms. All these things are impacted by the autonomic nervous system. And we'll be studying these using this COMPASS survey and then those autonomic testing profiles that Britt will be developing. It's important to understand the causes because that's what leads to the therapies that we're working on. So POTS and dysautonomia has specific therapies. If we find cervical compression on MRI leading to POTS and dysautonomia, that can be treated surgically. If we find hypermobility, that may be causing the problems. And if we diagnose POTS, there's specific treatments, both drug and non-drug treatment to specifically treat POTS, which can help fatigue and brain fog. If there's microbiome problems, there are potential therapies for improving the microbiome. And again, if there's inflammation, there are anti-inflammatory drugs. One that I'm going to tell you more about is using antibiotics like tetracycline as anti-inflammatories to inhibit central nervous system glial inflammation. We can work on dysautonomia through vagal nerve stimulation. And I'm going to tell you about an exciting study we're doing at Hopkins looking at altering neural networks using psychedelic agents like psilocybin. So you may have heard that Hopkins launched a psychedelic research center led by Roland Griffiths and Matthew Johnson. This psychedelic research center was funded by a gift from philanthropists, including the Cohen Foundation, and it's studying many illnesses, including opioid addiction, Alzheimer's, PTSD, and post-treatment Lyme disease. So we've actually started a pilot study looking at psilocybin psychedelics to impact the neural network changes that we think underlie some of the problems with Lyme disease. So this is a link that you can go to see if you might be interested or eligible for the study. I'll post this link later in the talk so you don't have to copy it down frantically. So this is one study that's going on right now at Johns Hopkins that came out of these studies, suggesting that neural mechanisms might be important. We've also, I have very good news for you. There's now a clinical trials network that Hopkins is part of. This was established by the Cohen Foundation. It's centered at Columbia under the direction of Brian Fallon. So Columbia is the coordinating center for the first ever clinical trials network. It involves Children's National in Washington, Hopkins in my center, UCSF with Charles Chu and other sites coming on to really establish the first nationwide network of like-minded researchers that are going to do clinical trials, to put into place studies to see if these therapies that we're hypothesizing can help our patients. So right now we're doing the tetracycline study. This is the link if you want to learn more about it, to see if tetracycline can help people with post-treatment Lyme disease syndrome because of its central nervous system anti-inflammatory properties. It's up and running. It's an active trial at Johns Hopkins right now. Finally, I want to tell you about education. We started a Lyme disease fellowship to train the next generation of Lyme disease researchers and clinicians. Hopkins, of course, is known for its tradition of education. We've modernized our facilities a little bit, not that much sometimes, but we still are one of the leaders in medical education. And we have a Lyme disease fellowship now. So any of you out there that know internal medicine or family medicine residents that might want to do additional training in Lyme disease, we have an up and running fellowship right now that are accepting applications because we do all three things: patient care, research, and education. So this has been a rapid fire talk. We're going to have time for questions. I just want to give you some takeaway points. First, the bullseye rash, while characteristic of Lyme disease, is not the most common rash presentation. It's not always present, and it's difficult to discern in dark-skinned individuals. We need continued education about what the rash looks like. It's not always a bullseye. And I frankly think we need our artificial intelligence app someday to really help people screen skin lesions so they don't miss the opportunity to recognize an early Lyme rash. Blood test diagnostics are still problematic, and clinical diagnosis remains the feature of diagnosis, although I've shown you that there's huge amounts of research and new diagnostics going on right now. Lyme disease can involve the heart, which can be life-threatening. We're just now scratching the surface of the impact of Lyme disease on the heart. And most importantly, there's an insidious epidemic of persistent Lyme disease-associated chronic illness and symptoms. I can't say enough that these symptoms of fatigue and brain fog are real. They're not psychosomatic. We're showing and publishing molecular and biologic mechanisms that show these are real and not psychosomatic. And these mechanisms are probably multifactorial, but they're the key to designing new treatments. Our brain imaging shows that neuroinflammation is one of the mechanisms that may need to be addressed. Our joint ultrasound studies confirm that the joints and soft tissues remain inflamed after treatment in some people, and that can require directed therapy. We're designing new diagnostics that don't rely on antibodies, but rely on gene expression signatures that change faster and it may be more accurate than antibody testing. And that all of our diagnostic toolkit and treatment options need to address all these potential mechanisms I told you about, whether it's immune dysfunction, microbial mechanism, co-infection, neural alteration. It's a complex system, but we're starting to dissect it and find the keys that will lead to better diagnosis and treatment. And part of the impetus for that, frankly, has been long COVID. There's an upcoming conference actually sponsored by the National Academies in June that's going to be looking at these chronic illnesses like long COVID, ME/CFS, and now long Lyme, because they probably share similar disease mechanisms. For instance, dysautonomia in POTS and other things I told you about. And so these common illnesses are going to be the topic of a National Academies workshop. And this is, I think, the first step in aligning all of these chronic illnesses for common research agendas to combine our forces to solve these problems. So we are really appreciative to the people that have funded our work, the Stephen and Alexander Cohen Foundation, Department of Defense, Health and Human Services, and in the past we were funded by Global Lyme Alliance, BALF, and many, many individual family foundations and donors that have made this possible. Our team is robust. Our clinical team, you probably all have met, that are spectacular. John Miller, our rheumatologist, Allison Redman, who basically designed the SLICE studies with me 15 years ago, Tang Yang, our biostatistician, Erica, our study coordinator, Verna, our regulatory manager, Cheryl Novak, who doubles as an angel, our clinical nurse practitioner, our second angel, Susan Joseph, our nurse, and Cindy, our frontline receptionist. And then really people all around the university. You've heard Pegah Taraji talk at this forum about neuropsychiatric things, Sherry Marvel, who's doing the neurocognitive imaging studies, and our lab at Bayview, and now more and more people around the university at the Applied Physics Lab, the Bloomberg School of Public Health. So it's a university-wide program at this point. We're going to open it up for questions and answers now. I'll leave the screen up so you can see some of the contact information, our website, which has tons of great information, pictures of tick bites and rashes, our study site where you can learn about our studies and the tetracycline pilot study, the psilocybin site, our main line here if you have a rash you'd like to contribute to our studies, our rash hotline if you have an active rash today, this month, that you want to be seen urgently for evaluation of an active rash, and then subscribing to our newsletter. So I'll leave this up and I'll open it up now for questions and answers. Nancy is going to moderate the question and answer period. Thanks, Nancy.
Sure. Thank you, Dr. Aucott, for your presentation. You can find the Q&A at the bottom of your screen. So if you have a question, please type it in there and I'll be going through them. We cannot answer specific patient health questions, but if you have other questions, we will get through as many as we can in the time that we have. Thank you. So let me start with the first one, which has to do with long COVID and long Lyme. This person has both and asks, is there anything being done to better understand and support those affected by both at the same time? I have both and I'm getting slammed and having a very hard time finding support and help with this. Thank you for any advice.
So actually there at Hopkins, there actually is a dysautonomia clinic that does care for both long COVID and long Lyme patients. That's the one that's now being started by Dr. Britt Adler. And so they do see patients because they're very convinced that there's a shared mechanism with dysautonomia, and that both long COVID and long Lyme trigger dysautonomia in POTS. And so the POTS dysautonomia clinic at Hopkins sees and it helps evaluate patients with both those conditions. And so that would be an appropriate place where they would consider both. The symmetry is that the common theme is likely to be dysautonomia, at least in part. And that would be a great place to start to look into that.
There's a question about congenital Lyme. Could chronic borreliosis be the outcome of congenital Lyme? And then another question, what are recommended treatments for Lyme disease during pregnancy?
So that clinical trials network that I mentioned to you on that one slide, the site at Children's National is actually doing a study that's now starting on congenital Lyme. So part of the clinical trials network, it's not a treatment study, but it's a study to understand the impact of Lyme disease on the fetus. And so the Children's National is doing a congenital Lyme study. It's starting this year, and they will be examining people that get Lyme disease relative to their pregnancy. It's a really, really good study because it's modeled after the Zika studies that looked at congenital Zika that Children's National did. And so they're really some of the world's experts on congenital Lyme. And so they're going to really want to understand this, people to enroll in the study. And so if you go to the Columbia website for the Clinical Trials Network, or you can find contact information for the Children's National Congenital Lyme Study. And I really, really would be great if people refer patients for that study. In terms of treatment, you don't use doxycycline for pregnant women because doxycycline is a no-no in pregnancy, but you would use other antibiotics. And so, and it's likely the kind of diagnosis that, again, you would want to go to a place like Children's National or a place with a big, maternal fetal program that understands these types of things. So I'm glad you asked that question because the Clinical Trials Network is actually really involved in this study to get this understood.
Why are patients with Lyme disease-like symptoms and an indeterminate Lyme test not routinely tested for Borrelia miyamotoi?
So that's a great question. The Borrelia miyamotoi testing has had a slow uptake, I'll be honest. I think it hasn't been taken up as fast as it should because we know miyamotoi is common on the East Coast and other places, so they should be. And that gets to the whole issue of chronic Lyme and persistent Lyme is kind of a neglected illness, and so we've got to constantly spread the word in education because I agree with that question. There's been very slow uptake in miyamotoi testing and it needs to be thought about more, and we've got to spread the word more and more. And that's a great question.
For someone diagnosed with post-treatment Lyme disease, which they believe occurred after a tick bite decades ago, where would you suggest they start as far as treatment? And how might the Venn diagram that you showed help put the puzzle pieces together?
Yeah, so I'm speculating now because I don't know the answer, but I'll speculate as long as you allow me to. I think patients that were infected decades ago, that the Venn diagram likely shifts towards inflammation and altered neural networks, because the impact of the bacteria-driven inflammation has had so long to dig in that it's probably had longer to impact the neural networks. And so I'm speculating, but I suspect that the Venn diagram shifts more towards autoimmunity and inflammation and altered neural networks. And I think that fits with our clinical experience, that patients with decades of chronic Lyme disease don't respond to repeated courses of antibiotics as well as somebody that's only been sick for a year or two. And I don't have data to prove that, but I think it's a clinical observation. But I don't have data. You allowed me to speculate, and so I did.
How does one go about getting an appointment at the center?
It's that 410-616-7596 number there. And you have, as all things in healthcare, it requires a physician referral. So we need medical records and your physician to refer you with records to that you call that number, and they'll give you the fax number. The fax number is actually 7595. And the physician referral and records then are reviewed. And that's the way we take people in for clinical evaluation.
Do you believe antibiotics are an essential part of helping a person heal from Lyme plus? Do you think Lyme plus is actually curable?
So by Lyme plus, do we mean?
I assume that means Lyme plus co-infections, but.
Yeah. I think that's the holy grail question, right? Is how impactful are repeated courses of antibiotics, and do they need to address more than Borrelia burgdorferi infection? I think that's the holy grail question. That's, one of the reasons we're doing the tetracycline pilot study, but that's the question. And the problem, the barrier to answering the question is there's no biomarker outcome measure that's easily available to correlate treatment response. All the studies right now, the treatment response is based on symptom improvement. And so that makes doing treatment trials difficult. I think that's the holy grail. It's also honestly hard to do co-infection testing. It's not easily available. It's very expensive at some of the best labs. And so doing co-infection testing is not a slam dunk. It's very hard. We've had a hard time getting co-infection testing in our research studies, actually. We've put in grants to study co-infections and have not been able to get funded to study that. So studying co-infection is hard because the diagnostic tests are hard to do. They're very expensive. And in the clinical realm, they're expensive. And in the research realm, we haven't been able to get that work funded. So it doesn't mean it's not an important question. I think it's one of the important questions that we have to answer.
What is the role of Epstein-Barr virus in Lyme disease? And if someone has MS, how can you tell if it is MS or Lyme? And are there studies to tease that out? Because there have been recent studies showing the relationship between Epstein-Barr virus and MS.
So that's an awesome question, because that's referring to Bill Robinson's work at Stanford, who's a collaborator of ours. And so Dr. Robinson and our team have looked at aspects of inflammation, and actually are planning on doing a Epstein-Barr virus study in post-treatment Lyme disease. That's our next project that we are planning on doing. So it's a great question, because Dr. Robinson published that great paper last year that implicated dysregulation of Epstein-Barr infection in the pathogenesis of multiple sclerosis. And we're basically going to do the same study in Lyme disease associated chronic illness. And we have the proposal out right now for funding, and I think we're going to do it. And so it could be an amazing breakthrough because, again, it gets to the complexity of what's driving illness. It may not just be one thing. It may be the Borrelia burgdorferi infection impacting the immune system. The immune system loses control of the chronic Epstein-Barr virus infection, which then triggers changes in, antibodies and inflammation that then cause the progression of diseases like MS and maybe Lyme disease associated chronic illness. So I'm actually confident we're going to do that study in the next couple of years. We have a proposal out literally right now that's being considered for funding.
Thank you. There's a number of questions about the study that you highlighted showing the 14% of post-treatment Lyme disease patients that were early diagnosed, promptly treated. And the question relates to how early were they treated, and presumably also a comment saying presumably the rate of long Lyme is much higher in those who go undiagnosed for a long period of time and take longer to get treated. So this is, in a sense, a best case scenario of long Lyme, and that in the general population, is it a greater number?
So I agree 100% with the statement. So as in not all studies, but as in most studies, to do research, you have to isolate variables, and you invariably pick the least complicated patients. So that's true for all research, whether it's, coronary artery disease or Lyme disease or MS. And so we picked the simplest model, which is early diagnosis. I mean, this was early diagnosis. Some of these people had only been sick for 5 days. So the question is absolutely right. This is the ideal setting, but we had to do that to get the answer. And then what the issue is that the comment is right, spot on, is you can't generalize those numbers to complicated patients. So if you have a patient that gets misdiagnosed, develops neurologic Lyme disease and doesn't get treated for a year, that setting, you can't generalize the 14% number to. You'd extrapolate and say it's probably a lot higher. Can I give you the exact number? No, but absolutely, I agree that it's likely higher. It may be as high as 30 or 40%. We don't know, because obviously you can't do a study in people that were misdiagnosed, right? I mean, you just think about the logistics of, they'd all be different because they would have had different misdiagnosis. They would have had such complex, pathways that they would all look different. And so that doing that kind of study is tough to do. Doesn't mean you couldn't do it, but for right now, I would just agree with the question, 100% right. This is ideal. So this is probably the lowest number, 14%, and complex cases are likely much higher.
Can the brain fog due to Lyme disease cause cognitive decline and lead to Alzheimer's disease or dementia?
So that's another really great question. We don't see that often, but to see that, you'd have to follow patients a long time, right? It would probably occur over longer periods of time. So I think we've not looked at it, frankly, because our study design isn't set up to follow people for the amount of time that you'd need. Doesn't mean it's not a valid hypothesis. And I think the whole field of inflammation and Alzheimer's is evolving. And I bet you we'll see studies that start to ask those questions about infection-triggered inflammation being part of the pathogenesis of Alzheimer's. So I think that's a future item that's likely going to get more attention. We've not addressed that in our first, areas of research because it would require study designs that went out a lot longer, and we weren't able to do these studies longer than 1 to 2 years for basically for pragmatic and funding reasons.
Are there any new treatments for chronic neurological Lyme disease?
So the treatment trial network is entertaining different possible strategies. I mean, I would say that our tetracycline study is one of those that may impact glial inflammation in the brain and impact beneficially, chronic symptoms. And then the treatment trial network is looking at other things. They're accepting actual proposals every year for new studies. And so I think that's going to be a primary that we'll be studying. The vagal nerve stimulation study, is looking at dysautonomia, and that's being done by Dr. Fallon's group up at Columbia. So I think the answer is they're coming.
Are you able to lecture at Harvard Medical School, and do ID docs at MGH and other institutions also have this information?
What school? What was that? I haven't heard of that. Where is that? Actually, I gave the keynote talk at the opening of the Lyme Center up at Harvard a couple of years ago. So I'd be happy to get invited again.
Let's see. Do many of your Lyme disease patients also have an intolerance to toxic mold?
So there's I didn't go into that because I didn't have time today, but I think we're seeing more and more that environmental factors that was in that Venn diagram, that was one of the areas, can have a really important effect. And the environmental factors can be environmental triggers of inflammation, like mold, which is a big environmental trigger of inflammation. So I think, yes. The other thing that's probably important to think about is mast cell dysfunction, because mast cells are part of your inflammatory system. And so triggering of mast cells, which then is also, an inflammatory process, may also get triggered by the inflammation of Lyme disease. So yes, anything that adds, it's basically adding insult to injury when you add more inflammation, whether it's from environmental sources like mold or mast cell activation, is definitely gonna be a cofactor to consider.
Do you have any studies regarding Margellans?
Nope, have not studied that. I'm sorry. Yeah.
And is there any research on biofilms?
The biofilm work is, most of that's done in test tube models. And so we're not test tube researchers. We're actually, patient-based clinical translational researchers. So it's almost impossible to do biofilm research in humans because we never get tissue. But it could be done it's done more in test tube models and animal models. There's also an autopsy study being done or being set up by BALF out on the West Coast. They have a biobank of autopsy specimens, and that's the kind of models that could be used for looking at biofilms. I don't have the link for the BALF biobank for autopsy specimens, but if you Google Bay Area Lyme Foundation and autopsy studies, you'd find that, and it's run by Liz Horn, and it's a very, very good study that it's collecting autopsy specimens, and that's the kind of study that could look at biofilms, but most of it right now is being done in test tubes labs.
And I'm just going to repeat that for the audience. It's Bay Area Lyme Foundation, the acronym BALF. Okay, next question. Have you seen any cases of Lyme disease presenting as synovitis, joint lining inflammation, instead of arthritis? If so, is the treatment different?
So that's that slide I showed you of Dr. Miller with the power Doppler images. Those red dots were synovial inflammation. That's basically blood flow in the synovium. And the whole premise is, with power Doppler showing synovitis, you can detect synovitis in people whose joint exams to finger exam, like a doctor uses, pressing and pushing, is normal when we palpate, but is abnormal on power Doppler. So that's exactly the premise of his research, is that, and it's the fact, he can identify synovitis in people with normal exams. And what that means is they need more treatment, because their inflammation isn't gone, and they need initially they may need more antibiotic treatments if they have late Lyme arthritis, or later on they may need also adjunct anti-inflammatory treatment. That's exactly John Miller's research using power Doppler. And it's going to revolutionize the field because, just think about it. Before we had ultrasounds of the abdomen, how did you know if somebody, had needed their gallbladder out? Well, you pushed on their gallbladder, and if it hurt, you took them to the OR. Well, we don't do that anymore. We do an ultrasound. Well, it's going to be the same thing with arthritis. You're going to do an ultrasound to determine whether the person needs more treatment, not just pushing on their joint.
Is there a way to tell if a positive skin biopsy for small fiber neuropathy is caused by Lyme disease or my diabetes? And this is a separate question. Are there any clinical tests that assist in making a diagnosis of autoimmune neuropathy post-Lyme?
So that's a tough question because you're right that the biopsy can't tell you the cause of the small fiber neuropathy. And so if you have both diabetes and Lyme disease, it can't distinguish those. It's all about the clinical context. In other words, if the small fiber neuropathy came on before the Lyme disease in somebody who had longstanding diabetes, it's probably due to the diabetes because it started before the Lyme disease. But if it came on after both of them, it would be hard to tell. If the diabetes had been poorly controlled, then it might point to the diabetes, or if the diabetes had been really well managed and controlled, it might point to the Lyme disease. But the bottom line is the clinician's going to have to make a clinical decision and potentially treat both of them, actually. And then I forgot the second half of the question.
Now I have to find it. I've scrolled down. Are there any clinical tests that assist in making a diagnosis of autoimmune neuropathy post-Lyme?
So that's actually what Britt Adler's research program is going to be about. So come back next year and I'll tell you what she's found. That's what she'll be working on.
I have both long COVID and Lyme disease for 30 years and now diagnosed with lupus. Is there a likely correlation?
So many of the autoimmune disorders can be triggered by infections. And it's been known for a long time that rheumatoid arthritis is likely triggered in part by gingival infections. And so autoimmune disease is part of the milieu that they form in are inflammation triggered by infections. That's seen in rheumatoid, and we think, I've told you today that we think that's likely the case in Lyme disease. And in that milieu, for instance, in Lyme disease, we are seeing people get triggered rheumatoid arthritis and psoriatic arthritis, and occasionally lupus. So the milieu, the ground in which autoimmune diseases emerge is often one that's laid by a previous infection causing chronic inflammation. And that's why we have to monitor our patients so carefully, because part of their chronic Lyme disease may be the emergence of a classic autoimmune disorder like lupus or psoriatic arthritis or rheumatoid arthritis. And those then need to be treated specifically for the lupus, right? You wouldn't, at that point, you have to treat the lupus itself. You can't cure the lupus at that point by treating just the Lyme disease.
This is from a Lyme disease patient advocate that specializes in the syndrome of multiple chemical sensitivities and wants to know how they can assist in having MCS included in your studies.
So I think that that's one of this family of disorders that we're interested in, is these illnesses that share a common symptom complex. So that's something we're very interested in. Again, this National Academies workshop is going to be trying to bring in these seemingly disparate, but probably not disparate conditions and try to get a common research agendas. And so I would encourage that person to attend that workshop as well. It's open to the public and to, start to get the involvement there.
I will just add that that workshop is taking place on June 29th and 30th in Washington. And it's also available via online. So, and it's open to the public, so you can register. There's a question about Lyme associated with mental illness and what treatments are available and how the center can be contacted. So the contact information is on this slide. And I guess you can answer the question about, is Lyme disease associated with mental illness?
Yeah. So I think that it's a really important question. I used to say, well, Lyme disease doesn't cause mental illness because I was focusing on the argument that it's not a psychosomatic disease, which I maintain is true. But I've shifted my answer to that a little bit because it's not a psychosomatic disease, but it is a brain disease, and involvement of the brain causes brain illnesses. And I think Brian Fallon is really one of the world's experts in the neuropsychiatric manifestations of Lyme disease. And he just did a study with the Dutch investigators last year, which is one of the more important studies in the last year, that showed that having had Lyme disease and being hospitalized for Lyme disease was a risk for the development of future psychiatric disease, not because the whole thing was a psychosomatic illness, but because Lyme disease impacts the brain with inflammation, and brain inflammation is not good for your brain. And that causes brain diseases like, schizophrenia and depression. And so again, it's sort of like my answer to the lupus question. Those diseases don't need to be treated themselves in and of themselves, because those are serious diseases. And, we do not have an expertise in that. I'm an infectious disease person, but it requires a experienced neuropsychiatric team as well, because those are serious life-threatening diseases, and they're real, and they're probably people with Lyme disease are at increased risk potentially. And then Nancy, I don't know if you want to mention, the contact number for crises, the hotline crisis number.
Oh, yeah, sure. I mean, well, that there's a text number and a phone number that you can easily access. And so if you're calling a phone number, it's 988. And if it's a text crisis line, it's 741-741.
So those are important crisis contact numbers, because these are serious diseases that are a part of the spectrum of what Lyme disease triggers, I think.
Can you discuss the tetracycline study again, your reasoning for testing tetracycline in Lyme patients, and if you could, in broad brushstrokes, explain some of the entry criteria?
So it actually goes way back to Sam Donta, which is one of the pioneers in chronic Lyme disease. He actually coined the term chronic Lyme disease. Sam Donta, over 20 years ago, did what are called open label studies of tetracycline. And open label means there was no placebo control. And so he published them, and they showed that longer doses and durations of tetracycline were very beneficial to people with chronic Lyme disease. He published those, but they were never followed up on. And because they were non-controlled, non-placebo controlled trials, they've never gotten traction, and they could never be used for the FDA to approve the drug for that indication. So I know Sam Donta, and he's been bugging me for 20 years to do the study. And finally I said, we'll do it. But we had to do it in a way that was really rigorous. Not that Sam Donta isn't rigorous, but he didn't have the resources to do a study. So I had to get an FDA approval to do the trial, because it's an FDA approved investigational drug at the duration we're using. So I hold the FDA approval to use the drug for long durations in this indication. That was in itself an incredibly complex process. I had to meet with the FDA and get their approval. I have to report back to them progress reports. And but we did it because of Sam Donta's observation that tetracycline improves people with chronic Lyme disease. It's not clear if it works as an antibiotic or an anti-inflammatory or both. We don't know the definite mechanism, although since then, there have been several trials showing that minocycline improves the outcome of neurologic diseases like stroke and just recently multiple sclerosis. So minocycline, which is related to tetracycline, there's numerous studies showing that they improve or impact neurologic inflammatory diseases. So there was a rationale to use it. We picked tetracycline because that's what Sam Donta used, and also minocycline is a little harder to tolerate. It causes more vertigo and nausea, so it has a higher side effect profile. I can't go into the actual enrollment criteria. That's why I gave you the site to go to, because that's where you can learn about it. But it's basically, I will say that, this gets back to the question about the SLICE study and generalizability. It's designed to try to have the highest chances of success. And so the enrollment criteria are fairly narrow because we want to pick a uniform population because we want it to have a highest degree of chance of success. And so that means the enrollment criteria are pretty precise because that's how you improve your chances of success. So you can go to that site and read about it, and you can actually, there's contact information to get screened for the study at that site.
What is the terminology to use to refer to patients who suspect Lyme disease but were misdiagnosed and not treated early? Chronic Lyme or late stage or?
Yeah, so that's why I put that one slide up. It changes every year or two. So I'm avoiding picking a name because honestly, it doesn't matter. It's all pretty much the same thing. Recently I've been using long haul Lyme because people could equate it to COVID, and there's more acceptance of long haul COVID, and it's a similar illness. A lot of the advocacy groups are using persistent Lyme. This National Academies thing is using infection-associated chronic illness. It changes every 2 years. I think what you don't want to do is, pick a term that's polarizing, because when you see somebody, and I do this myself, I don't want to polarize the discussion. So I pick a term that opens up the discussion and doesn't polarize it, because it really doesn't matter to me. What matters is it's real. We don't understand what causes it, and we need to figure it out.
There's another question pertaining to Alzheimer's. The Borrelia burgdorferi bacteria have been identified in amyloid plaques. Does this indicate a role for Lyme disease and Alzheimer's? So
I think that question is referring of one of the maybe one or two publications that are preliminary speculative reports of an association. And I think that's the starting place to raise the question, but it's nowhere near the answer or proof. But it's a good starting place. It raises a question that now needs to be investigated.
What are your thoughts on heavy metals that are high in Lyme disease patients?
That's a very complex area that I'm not an expert in, but we do screen for heavy metals in people that have occupational risk factors. And so it's sort of one of those things people forget to do. And so we do, if there's an occupational risk, and so we'll do that. Hopkins has a big occupational medicine division, and so they're experts in that. So we would refer the patients to that group in the School of Public Health. But I think it's something to think about, especially when there's an occupational risk. I'm not going to comment on the dental amalgam issue and heavy metals because it's really complex and I don't know and not qualified to discuss that.
So there's a number of questions on alternative treatments, on holistic approaches, on health and wellness approaches, herbs and supplements. Can you just comment on some of those approaches?
Yeah, actually, Nancy and I, along with the Lyme Care Resource Center put together a brochure on exactly that. And I think Phil may be talking about that later. We believe strongly in complementary approaches. And so we've done a lot of research. We're not experts in it, but we've reviewed a lot of the literature, and we feel strongly that there's things that can benefit people. We also feel strongly that there's things that probably don't benefit people, but that's true in anything. So I think there is a caution that we advise, especially if things are super expensive, but there's a lot of things that are reasonable to think about. And the brochure that the Lyme Care Resource Center has, Nancy was involved in that, and I was involved, and we believe in doing that as a complementary approach to what I do, so as a team effort to help patients.
We will be sharing that at the very end. Phil Kenny's going to share that with us. There's a question about the need for increased funding and grants to further research and discovery. And if you could just update people on how you get funded for your research and what that environment looks like presently.
So unfortunately, Lyme disease is a neglected illness in essence, in terms of funding, because it for some reason never seems to hit the high profile media stage. It always gets knocked off by a higher profile illness. And if you look over, Lyme disease started at the same time as HIV, and it's always been in the background of one of the high profile pandemic infectious diseases, whether it's AIDS or Ebola or Zika or now COVID. And so it always gets knocked off the stage and never seems to get the high priority funding initiatives. And so, we wish there was more funding, because it's an insidious epidemic, but it's an epidemic. Again, 500,000 people affected every year. And so it needs research funding, and research is expensive. And the other problem is there's not a lot of pharmaceutical company involvement in Lyme disease, and that's where a lot of the money in biomedical research comes from these days, are pharmaceutical companies, and there's really no pharmaceutical company interest in Lyme disease for their own reasons. And so, yeah, it's a big issue. I mean, there are advocacy groups. Bonnie Crater leads one that's working on advocacy, and I think that they're working really hard on it. There have been some successes. The DoD research program was a success. That funds a lot of research now that was started because of advocacy. So I think there are successes, but research funding's really the linchpin of progress. And the funding for Lyme disease is doesn't even get close to comparison to other epidemic diseases.
Are there clinical training and educational opportunities for nurse practitioners?
Oh, that's a great idea. I'm not aware of any, but that's a really fantastic idea. I think there needs to be. In our center, our nurse practitioner, Cheryl, is right now, I would say one of the best Lyme disease practitioners in the country. I mean, she's amazing. And nurse practitioners have a special art of medicine that's, I think, really special and particularly needed in Lyme disease.
There are so many questions. I'm still going through them, folks. Let's see. Is there any correlation between multiple rashes upon contracting Lyme and the likelihood of then developing chronic Lyme?
We've looked at that in our SLICE cohort, and we thought there would be. And actually, we don't see a high association, interestingly. Other people have published that the more severe the symptoms are, there might be an association with chronic symptoms, but the multiple rashes actually has not panned out in our study. It may be because the people with multiple rashes get a really robust immune response. And so that robust immune response may be a good thing. It probably is a good thing. Early on, at least.
Can you explain in a little more detail how Lyme disease affects the heart And does it cause serious electrical issues?
So in the second stage, weeks 4 to 8, it's a direct infection of the bacteria of the heart muscle. And that bacterial infection triggers inflammation, which inflames the conduction system. And when the conduction system gets inflamed, like everything in the body, it's unhappy and it stops transmitting the electrical impulses efficiently. And that's called heart block. It causes a slow heart rate. And if your heart rate gets slow enough, your blood pressure drops. And if your blood pressure drops enough, you pass out and even die. So it's a direct manifestation of bacterial infection of the heart. The later issues of cardiomyopathy are less clear. Those probably aren't the direct impact of active, robust infection. They're more akin to, post-treatment Lyme chronic illness, where it's probably then more a mixed bag of chronic inflammation in the impact on the muscle function, not the actual robust infection that you see in that early myocarditis phase.
Does Lyme disease show in a regular MRI?
Of what organ? So, of the heart, actually, the MRI is abnormal in myocarditis. In the brain, it's not uniformly abnormal. That's why we had to do the functional MRI, because the functional MRI is basically a stress test of the brain. It's like the difference between a treadmill cardiac stress test and a resting EKG. The resting EKG, doesn't show anything in heart disease, and the resting MRIs don't show a lot in resting Lyme disease. But when you do the stress test, the functional MRI, that's where we see the changes in Lyme disease.
Well, thank you, Dr. Aucott, for answering all those questions and for a great presentation. I'm sorry that we're running out of time to address all the questions. There were so many good ones, and we apologize we didn't get to them all. But we hope that Dr. Aucott's update brings you hope in that we're making progress. Research is validating that Lyme disease is real, measurable, and biologic, and that there are therapeutic solutions available and on the horizon that can help patients heal. Thank you, Gina, Shireen, and Phil, for all your efforts with this event. Your steadfast support of our efforts at the Research Center are greatly appreciated as well. I'm now going to introduce Phil Kenny, one of the founders of the Lyme Disease Resource Center, along with the Lyme Care Resource Center, along with Shireen, and who was the other founder. And we love collaborating with you all at the Lyme Care Resource Center, and agree that together we can do much more. So thank you. And now it's over to Phil for closing remarks.
Thank you, Nancy. John, we cannot thank you enough for the information you gave to us tonight, all packed in just a short period of time. So thank you so much for the presentation, the information. We're so excited about hearing the collaboration, the clinical trials coming up. So thank you again. Thank you for your friendship and caring so much about the Lyme disease community. Nancy, thank you for your help over the years as well. What you see in front of you, folks, is the Lyme Disease Recovery Health and Wellness Tips brochure that we put together a couple of years ago. And it's got great information in there, collaborative actually just collaborative effort of folks who have found ways to cope with hope when they're dealing with this long haul Lyme disease. So some of the things in there I've done myself. All of them are helpful for body, mind, and spirit. So it is a total, just great ideas. You can get it for free, download it from our website, or contact Gina, she'll mail you hard copy. There's also another piece that goes with it. It is a tracker. This is page 2 of the tracker of coping with Lyme disease. So they're just great ideas about reflections that you can say attitudes to have towards coping with this or any chronic situation. And on the flip side, there's a weekly chart. So you can keep track of how your week's going on diet, health, exercise, your mental attitude, meditation, whatever you want to do. Then you can add to your own things at the bottom. So those are both complimentary, either online or contact Gina. So this is our 7th annual meeting. And we want to thank those who have been following us all these years. This is our contact information, our website, and our mailing address. So we're doing some fundraising. Very generous donor is matching funds. So we're for every dollar that is donated, if you donate $50, it's going to be $100. $200 is $400. So all the month of May, we're going to be, any money that comes in, we're going to be matching that. And 50% of the donations, 50% of everything that comes in is going to go to John's research. So John, that's just letting us know how much we appreciate you and all the work you've done over the years for the Lyme disease community. So there'll be matching funds dollar for dollar, and 50% go to Johns Hopkins Research, John Aucott. So John, again, we thank you for what you've done over the years. I want to thank you again, Nancy, and Shireen. Gina, thank you for the years of support. And John, when we met in 2008, you said, yeah, doesn't matter what you call it, we got to find out. We got to find out and fix it. And that's what you're doing. Folks, if you don't know, he started in his own office doing this research on his own. So thank you, John, again, for all of your friendship and all the work you've done for this community.
Thanks, Phil. It's an honor to be part of your team. Thank you.
And thank you, everybody, for coming tonight. We wish you all health and happiness. Blessings to you and your family. Good night.